The contents of this presentation are those of the authors and do not necessarily represent the official views of, nor an endorsement by, the Centers for Disease Control and Prevention, the U.S. Department of Health and Human Services, or the U.S. government. Hello. I'm honored to present to you today on behalf of the CDC and American Academy of Pediatrics, Lead Poisoning Prevention Online Training Program Module 2, Strategic Planning and Implementation of the 4 Key Strategies of a Lead Prevention Program and Evaluating its Impact. This presentation will cover the key strategy of surveillance and how you can create, maintain, or enhance your blood lead surveillance program. There are images featuring a father with a young daughter in his lap, a picture of a mother and child at the doctor's office, and a classroom with diverse students. In the bottom right is the Centers for Disease Control and Prevention logo, which also shows that CDC is a part of the Department of Health and Human Services. The purpose of this module is to introduce CDC's strategic priorities and outline proactive steps that can be taken to aid in the elimination of childhood lead exposures. This segment is designed to assist trainees in developing surveillance procedures for the collection, quality, assurance, analysis, and dissemination of child lead exposure blood test results and data. So, what is public health surveillance? The World Health Organization defines public health surveillance as ongoing systematic collection, analysis, and interpretation of health-related data essential to the planning, implementation, and evaluation of public health practice. Similarly, CDC defines public health surveillance as the regular collection, analysis, use, and sharing of data to prevent and control disease and injury. In a 2017 paper in the Annual Review of Public Health Journal, Grosclose and Buckridge identified 7 basic surveillance system processes. These include data collection, data quality monitoring, data management, data analysis, analytical interpretation, information dissemination, and application of information into public health programs. The final piece of applying the information is really what surveillance is all about, taking the raw data and being able to utilize it in an effective manner to drive positive public health outcomes. So, why is public health surveillance important? It is information that drives action. It can be used as an early warning system for disease outbreaks or syndromes, helps to guide public health policy and strategy, and drives public health efforts. It also identifies specific individuals impacted and can be beneficial in identifying high-risk areas and ensure proper care and follow-up, and documents the impact of interventions and progress towards program goals. Why is this important for lead poisoning prevention? Routine surveillance allows programs to identify individuals who've been exposed to lead and link them to the proper services. It can be useful in identifying areas within jurisdictions where there's an increased exposure and where public health outreach and education efforts may have the most impact. It can also help to guide funds to areas and programs that need it. The CDC has identified 3 main priorities relating to surveillance of lead. Priority 1 is to develop, update, or maintain a blood lead surveillance system that collects and tracks all blood lead test results and follow-up data on children with higher blood lead levels. This includes environmental source investigations and referrals to recommended services. The second priority is to develop and implement plans for collecting surveillance data, ensuring the quality of the data, and disseminating data with a focus on system interoperability. Priority 3 is to conduct analysis of surveillance data to identify lead-exposed children, high-risk populations, and geographic areas that could be at high risk of lead exposure. Within Priority 3, there are 4 additional points of emphasis. The first is collection, analysis, and interpretation of health-related data use for the planning, implementation, and evaluation of public health practice. For childhood lead poisoning prevention, this means being able to use the surveillance data collected to guide program activities and to use data to document and show how planned activities are being effectively implemented. The second emphasis in Priority 3 is to use the surveillance system to organize data within the tracking system, monitor health trends, determine risk factors, target interventions, and guide other public health actions. Having the data easily accessible and creating systems will assist in identifying trends or high-risk areas. State CLIP programs are responsible for managing local and state data. In Michigan and other states who provided feedback for this presentation, the blood lead test results are reported to and collected by the states. The states then process the data and then ensure it is sent out to local jurisdictions, who are responsible for case management. The data, coming from a central source at the state levels, allow implementation of oversight and quality assurance procedures. In addition, this process ensures that case management follow-up is documented. Finally, in Priority 3, the CDC requires that the data be managed within surveillance systems that are managed by surveillance professionals. These folks work together with programmatic professionals to interpret the data and ensure the data are used to identify targeted areas for blood lead testing and education and outreach efforts. Another requirement from the CDC Cooperative Agreement, an award for CLIP programs, is the development of a data management plan that outlines the following: the data that will be collected, standards for how the data will be collected or generated, mechanisms for or limitations to providing access to and sharing of the data, and a statement of the use of data standards to ensure all released data have appropriate documentation describing the methods of collection, what data represent, and potential limitations for use. As a final component, plans for archiving and long-term preservation of the data should be included. An example of CDC's data management plan can be found on the CDC Childhood Lead Poisoning Prevention website. CDC does not require this exact plan, but does require all plans to cover the 5 elements outlined on this slide. Surveillance is not a one-size-fits-all approach. Different states and jurisdictions have different needs depending on state legislative rules and requirements, higher blood lead level case definitions, testing and reporting requirements, and program capacity. When looking to develop or adopt a system, one should look at many factors, including existing state infrastructure, IT support, and funding. Ensure, when developing a system, that you understand the capacity of the program and the amount of effort it will require to align goals and expectations accordingly. Additionally, because surveillance systems across states are all different, it becomes difficult to aggregate data across jurisdictions. This also makes it difficult to create a national report on lead. Even within jurisdictions, the setup of different data systems can make communication and data sharing between them difficult. To show just how much variation there is in systems, the result of a 2019 survey of state blood lead surveillance systems are shown here. You can see the different systems in place for lead surveillance across the country, including 21% using custom web-based applications, 11% using Access or other relational database, 25% using the Healthy Homes and Lead Poisoning Surveillance System, or HELPS, 33% using a communicable disease integration like National Electronic Disease Surveillance System-based system, NBS, or Massachusetts Virtual Epidemiologic Network, or MAVEN, and 10% reported using other systems. This variety shows that there's not one system that works for everyone, and to explore what options may be out there that best meet the needs of the program. Pie chart showing types of data management systems. When developing a surveillance system, there are 4 core functions that the system must address regarding data. It must be able to collect, process, analyze, and report. Within the blood lead surveillance systems, there are many steps that correlate to each of those 4 functions. As you can see in this flow diagram, the results must be reported to the state programs, processed and cleaned, analyzed and aggregated, and finally, reported out. Each state has different systems in place to ensure this process is functioning for them, but the overall concept is the same across the board. Over the next few slides, I'll dig a little deeper into each of the 4 functions and what steps are included in them. First, you need to know who's testing in your state and jurisdiction. Tests can be performed in office on point-of-care testing instruments, or blood lead samples can be sent to reference laboratories. You must establish a mechanism for reporting results and then determine how the results will be reported to your program. Options include sending electronically through HL7 messaging, which are electronic messaging standards, or setting up secure file transfer applications for the lab to upload electronic files. You should explore what methods your state has in place and determine how best to establish these connections. One important aspect of surveillance is the concept of quality in equaling quality out. A system is only as good as the data coming in. Ensuring all laboratories are reporting test results and routinely checking the data for quality issues are vital to establishing a surveillance system and improving reporting downstream. It's better to identify data quality issues at the source than trying to clean up after the fact. When a physician orders a test, it can either be completed via capillary draw or venous draw. In most jurisdictions, capillary testing is considered a screening test, and any higher results should be confirmed with a venous test. Some physician offices, local health departments, or other health agencies have point-of-care testing that provides in-office capillary testing for lead. These results can be quickly obtained. In most jurisdictions, capillary testing is considered a screening test, and any higher results should be confirmed with a venous test. Clinical laboratory testing uses more advanced testing methods for both capillary and venous samples. Multiple methods include inductively coupled plasma mass spectrometry, or ICP-MS, graphite furnace or electrothermal vaporization atomic absorption spectrometry, GFAAS or ETAAS. These methods allow for more precise testing of the samples and reporting across a wider range of concentrations. Laboratories have different lower and upper limits of reporting based on the capabilities of their laboratory-developed tests and their laboratory policies. Establishing a system that can show when results are below the limit of detection is important when performing future analysis. Reporting requirements also vary by state. Some states only require reporting of children. Others require reporting of any test performed on a resident of the state. This contributes to the no one-size-fits-all dilemma, and you must determine what makes the most sense for your program and what legislative rules and requirements may be in place. A state surveillance system should be able to easily process, clean, and validate the data. When establishing a system, one must determine how the reported results will be processed and loaded into the system, where will the results be stored, and how to ensure all relevant data points are collected. Next, the system must be able to identify higher blood lead level cases and establish a mechanism for referring those cases to the appropriate partners. Think of the programs that are necessary to complete care and whether relationships have been made between your program and those programs. Some examples include Medicaid, early on, or local health departments. You must determine if data use agreements or system interoperability agreements are required to share the necessary data. It's important to build in quality assurance and quality control measures within the system. You must ensure any system created can identify data quality issues, and you must establish mechanisms for updating and correcting these issues, as well as notifying labs who may be causing the problems. Some questions to ask while setting up the system include: what are the most common data quality issues that you see? How are these issues identified? And who's responsible for correcting the issues and working with the submitters? Consistent and frequent quality checks are important to correct records and to identify any systemic issues that arise. Another important factor is to establish connections to other systems. Examples of this include linkage to Medicaid, immunization registries, and other centralized data repositories. This can assist in notification of lead results and coordination of care and services. To properly analyze your surveillance data, having sufficient and highly capable data management and analytical staff is a must. This is vital to ensuring the systems are working as expected and that the data can be utilized appropriately. Analytical staff will allow the program to work with the data and use it to identify problem or high-risk areas, and allows program staff to perform outreach. But more importantly, proper analysis of data can be leveraged along with other census and demographic data to drive primary prevention activities, which can eliminate childhood exposure to lead. Some common analysis for blood lead programs include calculating the number and percent of children tested, or the number and percent of children with levels above the blood lead reference value, calculating Medicaid testing rates for compliance with Healthcare Effectiveness Data and Information Set, HEDIS, measures and Medicaid testing requirements, determining the percent of children with levels above the blood lead reference value who are linked to services, calculating what percent of higher capillary results receive a confirmatory venous test, and reporting on testing information based on geographic distribution and amongst different demographic groups. Being able to perform this analysis and break it down by geography, local health department, city or zip code, or even down to the census tracts can assist a program with identifying areas that need additional support. Also, being able to perform this analysis at a granular level can help to show how targeted interventions within local jurisdictions are effective or whether the approach needs to be altered. Within the CDC Cooperative Agreement, state programs are required to report data quarterly to the CDC. You must ensure any surveillance system that is set up can meet this need and fulfill the agreement requirement. In addition to CDC reporting requirements, additional reporting can be useful to keep stakeholders and the public informed. Some states have required reporting to their government, and other metrics can be developed and used to determine program successes and show progress towards stated objectives, outcomes, and performance measures. Disseminating aggregate blood lead data routinely in reports helps to drive activities outside of the program as well. Aggregate data can be used by local jurisdictions to improve funding, and in grant applications, can be used by stakeholders to direct local lead activities and can be used to justify funding and program support. An example of how the blood lead data are disseminated in Michigan includes posting quarterly updates to the state tracking website, which makes annual data available to the researchers and to the public. Additionally, local health department reports are created quarterly and provided to assist in ensuring local work is making an impact. Data are also used to target areas of the state where testing rates are low to increase provider education and to ensure testing of at-risk children. Proper dissemination of blood lead data is what drives the work on the ground to reduce exposure to lead and ensure that primary prevention strategies are targeted in the areas where they will have the most impact. There are questions to consider when establishing a surveillance system. What are the needs of the program? Do you have any legal requirements, state reporting rules, or other direction from within your jurisdiction that the system must meet? And what are your objectives and end goals? What type of system will be used, and are there any existing applications? Is there anything established within your jurisdiction that can be leveraged, or would you need to look into something like the Healthy Homes and Lead Poisoning Surveillance System, or HELPS, that's provided by CDC? Be sure to build or utilize a system that can handle the capacity of testing, reporting, and processing within your jurisdiction. You need to determine how labs can report, and if you need to manually format the files for loading, or if your system accepts electronic or HL7 messaging. Also, what kind of IT support do you have to maintain your system? Hosting and maintaining a system can be difficult, so ensuring IT support is vital to getting it set up and reliably working. Also, being able to modify your system as different needs are identified and having flexibility within IT support can help meet the changing needs of the program. A great excerpt from the Grosclose and Buckridge article states the importance of outlining clear objectives for your system. The process and components of a public health surveillance system should be aligned with the objectives of the surveillance system to ensure that valid information can be derived and applied to practice, to promote operational efficiency, and to ensure that the activities are within the legal or regulatory mandate of the public health system. Explicitly documented objectives for the surveillance system are also important for planning the system, evaluating the system, and enabling continuous improvement of data and system quality. Making sure that you have clear goals will help give the program direction and help to show progress as you set up the system. Being able to set and meet goals can justify your program and ensure continued funding and support, and it will also have a positive impact on the public and on stakeholders. As part of the planning and research for this training, we reached out to other state programs to get their recommendations for how to establish a successful surveillance system. A surveillance system requires support and backing from the state in terms of staffing, funding, and commitment of resources. You should set SMART goals, which are specific, measurable, agreed upon, realistic, and time-related goals and objectives. You should utilize other states' knowledge and resources. You don't have to reinvent the wheel if there's something out there that'll work for your program. Ensure that financial support and IT resources are available prior to starting. Ensure completeness and accuracy of the data on a routine basis. And ensure the ability to link blood lead data to other health-related data. And on that note, I'd like to thank the following states and their representatives for providing feedback for this training: Alabama, Arizona, Illinois, Indiana, Iowa, Louisiana, Missouri, Ohio, and Wisconsin. As mentioned previously, each state is unique in how it manages blood lead surveillance, and ensuring input from multiple jurisdictions allowed me to provide you with their experiences and recommendations for establishing or maintaining an effective system. This presentation was developed in collaboration with the American Academy of Pediatrics and Dan Albright, a data manager and departmental specialist for the Michigan Childhood Lead Poisoning Prevention Program, or CLIP. The contents of this presentation are those of the authors and do not necessarily represent the official views of, nor an endorsement by, the Centers for Disease Control and Prevention, the American Academy of Pediatrics, the U.S. Department of Health and Human Services, or the U.S. government. I'd like to thank you for viewing Module 2, Segment 2. For any questions or comments regarding this segment, please send an email to ledinfo@cdc.gov and indicate Training Question Module 2, Segment 2 in the subject line. Thank you for your time, and good luck on your future endeavors.